the
Dr. Deepthi
topic.
approach to a case of to a case of TBM. Good afternoon, everyone. Before I start the topic, I have a little bit of instructions to make it a little more interactive. You can type your questions on the chat and I'll note them and I'll answer them. You can type on your mobile or internet browser www.menti.com. I'll tell you the instructions as we go, just in order to make it a little more interactive. I've introduced this layer of technology. Let's see how it works out. And sit with a paper and pen if possible so that you can note your own answers if that strategy doesn't work out. So today I'll be talking about how do I approach a newly diagnosed case of tuberculous meningitis. We'll be going about in talking about the clinical clues and criteria, the red flags, and how to follow up. This might be a little monotonous, so I have tried to break these headings by going along with the cases and then discussing these headings in context with the cases. So I hope we can, although we cannot see each other, we cannot talk to each other, we will still be interacting with each other. So clinical clues and criteria. Whenever a patient comes and the resident presents that this is a known case of tuberculous meningitis, the first thing is to act like a devil's advocate. It can be anything else, but it can also be tuberculous meningitis, should be the approach. And before we get distracted by things on the right, I will take you to the case in which there is a 23-year-old lady who is a sister of a medical doctor, brought from another city after 8 months history of intermittent headaches, 1 episode of seizure with loss of consciousness and altered sensorium, 6 months after the onset of headaches. And then she was started on anti-tubercular treatment from outside, which she's been taking regularly for 2 months. And then she came to us. Why did she come to us? Because there was headache and fever which was persisting, which did not subside even after the initiation of anti-tubercular treatment. There was no resolution of symptoms and she was not able to get back to her study or her work. And there was worsening with steroid tapering. So as soon as she would taper steroids, the symptoms would recur and they would be really bad. When we saw her on general examination, she was normal. The systemic examination did not reveal anything significant. Chest was normal. Conscious, she was oriented. There were no meningeal signs. However, all the deep tendon jerks were exaggerated, although they were symmetrical. On investigations, we saw that the CSF pressure was normal, cells were at 100 with the lymphocytes of 100%, proteins were slightly raised at 58 mg%, and sugar was 57 mg% against a corresponding of 110, so it was a little less. Cryptococcal antigen was negative, cytospin was negative, gene expert was negative. And this was her imaging. As you can see in the T1, we don't see anything remarkable. In the T2, we see that there is a hyperintensity in the cerebellar hemisphere, which is enhancing on contrast. And then you can see few ring enhancing lesions in the left frontal area and in this cistern. And the chest X-ray was essentially normal. So what will you do? So for here, I go to a browser and we start with this presentation. You have to, if you have already typed on www.menti.com, you can use this code 80898 and then you can start putting in the options. You'll get this, you'll get a name, you can just type on that and then you can start pressing your options. I can see the responses if they come here. If they don't come here, you can just write your response as to what you will do on a piece of pen and paper. That's also okay. So will you add a second line treatment? Will you do a whole body PET? Will you do a repeat CSF sample for malignant cells? Or will you give a prolonged course of steroids? So I don't see any responses here, but I think in the second question, when we get the hang of this, we'll be able to see a few responses. Now, how do we diagnose? Now, the first time we had a very systematic diagnostic criteria was published in 1994 based on this randomized control trial of dexamethasone and tuberculosis, which was a work done by AIMS New Delhi only. And I see the names of two of my teachers here, Professor Bihari and Professor Prasad. This is a trial done in 47 patients. And the clinical criteria, the diagnostic criteria are interesting because as we go through the timeline, we'll understand how they've evolved over time. So you can see that the clinical criteria consists of fever more than 38 degrees centigrade with headache, neck stiffness, with or without seizures or altered sensorium, and the cutoff is of 2 weeks or more. The characteristic CSF picture shows that there should be leukocytosis with lymphocytic predominance, a protein of more than 1 gram percent, and a sugar of less than 2/3 of the corresponding blood sugar, with negative cultures for pyogenic, fungi, negative cytology for malignant cells. That is what we essentially do in patients with chronic meningitis. And the contrast CT head, which showed basal exudates or hydrocephalus with or without infarcts and tuberculoma. The clinical, radiological, and histological evidence of extracranial tuberculosis further reinforces the diagnosis. From here, there was a further study in pediatrics published in 1999 by Dr. Rashmi Kumar, and she also happens to be one of my teachers from King George's Medical University. And this was a study in pediatric patients, children, 232 children, which showed that a prodromal cutoff here, they took a cutoff from the beta coefficient of 2.33. They took that if the prodromal stage is more than equal to 7 days, if there's optic atrophy, if there are focal deficits, if there are extrapyramidal movements, and if there is a CSF leukocytosis of more than 50% with less than 50% polymorphs, it is suggestive of tuberculous meningitis. So here we see that the cutoff decreases from 2 weeks to 7 days, and then further was the Thwaites criteria, which was again based on a study in 251 patients, in which they took out this criteria and they made a diagnostic index wherein if the score was less than or equal to 4, it favored TBM, and if it was more than 4, it favored acute bacterial meningitis. So the age of more than 36 favored tuberculous meningitis, less than 36 favored tuberculous meningitis, and a leukocytosis of more than 15,000 favored bacterial meningitis. Here we can see that the history of illness of days further shrinks down by a day. So here the cutoff was more than equal to 6 days would favor tuberculous meningitis. A CSF pleocytosis of less than 900 cells would favor tuberculous meningitis, and a CSF percentage of neutrophils less than 75 would again favor tuberculous meningitis. And after that, there was this diagnostic criteria for research purposes, which was published in Lancet Infectious Diseases in 2010, which was a combination of CSF investigation criteria. So here we can see that in the clinical criteria, the cutoff further shrinks to 5 days. And the CSF appearance and all those criteria are more or less the same, except for the range has become a little more precise, 10 to 500 cells. The CSF imaging criteria included hydrocephalus, presence of basal meningeal enhancement, tuberculosis, infarct, pre-contrast basal hyperdensity, evidence of tuberculosis elsewhere, and exclusion of alternative diagnosis. But this is the most important part, because this diagnostic criteria, although it is not for uniform clinical use and it is more for clinical research, this part of the criteria is especially interesting because it gives us a whole checklist of what all we should essentially exclude, namely syphilis, lymphoma, pyogenic meningitis, cryptococcal meningitis, viral meningitis, cerebral malaria, parasitic eosinophilic meningitis, cysticercosis, toxoplasmosis, brainstem abscess, and lymphoma. Having got to those exclusion criteria, which gives us a fair idea of what those red flags are, How did we identify when the patient first time comes to us? Now from here we go to case 2, where this is a 21-year-old male with intermittent fever of 1 month duration, headache of 7 days, vomiting of the same duration, and then he developed right-sided weakness followed by altered sensorium of 1 day. Now in this particular patient, on examination, he was drowsy but arousable. The general and systemic examination were normal. The meningeal signs were present. There was bilateral 6-nerve palsy, and the right lower limb was weak distally. He was not cooperative for a complete sensory examination, and the deep tendon jerks were attenuated in the lower limbs, in both the lower limbs for that matter. On CSF examination, there were 110 cells with 100% lymphocytes, a protein of 81 milligram percent, sugar of 48 milligram percent against a corresponding of 208 milligram percent. Cryptococcal antigen, cytospin, and gene expert were negative. And this is his imaging, which shows essentially that in the CT there is a hypointensity in the left frontal and the right parietal area. And here we can see they are not corresponding images, but you can believe me because I've just taken out the representative images from there. There are some ring enhancing lesions in the contrast study. And so in this particular patient, what do you think is the cause of lower limb weakness? I will try again to be able to get to this. So let me switch on to the second option, and the code is the same. You type on, you get to menti.com. There is a code which you need to enter, and you enter the code 80898, and as soon as you plug in your response, it does come here, so you can even see it. So maybe I can wait for 30 seconds and see if it is working, or if any one of you is trying. And so I do see that it's working, at least in one person. So yeah, so you just need to pin in your response, and we can see it all here. So maybe I can wait a little more for other people to respond. And even if you're not able to get there, doesn't matter. You just write your response somewhere, or you just register a response somewhere, and then we'll get back to these cases. Okay. So the possible options were that could it be arachnoiditis? Was it myelitis? I already showed you the MRI of the spine. Was it a tuberculoma, or was it demyelination masquerading as tuberculosis? Now from here, we move on to another case with a red flag, and then we'll go back and discuss both these cases together. So that is why I said that you can register responses, because we'll be going case wise, and then we'll be probably going back to the cases and seeing the learning points from these cases. So case 3 is a 35-year-old male with headache and fever of 2 months, vomiting and intermittent vision loss of 1 month, and drowsiness for 2 days. He was conscious, but he was a little drowsy. On general examination and systemic examination, there was nothing significant. He had terminal neck rigidity. Terminal rigidity means that you're not sure. Although he had bilateral disc edema and the cranial nerves were normal, there were no focal neurological deficits. On the CSF examination, his pressure was more than 30 centimeters of water. Cells were 5, 100% lymphocytes, glucose of 13 against a corresponding of RBS of 120, and this is important, a protein of 181 milligram percent. And this is his imaging. I would apologize if they're not showing up very well on your system, but yes, you can see that T1 is essentially normal. The T2 doesn't show you that there is effacement of gyra sulci, or the cisterns can be made out. This is the contrast imaging, which shows that there is essentially doubtful, if we're to say, and that was what was the real impression given to us. Leptomeningeal enhancement, especially because we did it after we had drained CSF, so that could have been falsely enhancing. And this is the SASH T2, which doesn't show any specific midline space occupying lesion. So what are the possibilities here? And I would again venture here and let's see if it works out. So what are the possibilities? Is it tubercular meningitis? Is it IIH? Is it a dural AV malformation? which is causing these symptoms related to raised ICP, or is it other chronic meningitis? And you can give your responses. I'll see if it works out. The code remains the same. It is 80898. So I can see that very few are responding, but nevertheless, I think it's the first try that we are going, and maybe when we do it subsequently, we'll be better in going about it. Okay, so then I go back to my presentation. So the red flags here, or for that matter, in any situation in which you're seeing and the possible clinical diagnosis could be tuberculous meningitis, are the presence of normal cells, repeated high pressures, no response to treatment like we had in our first patient. We could think of multi-drug resistant tuberculosis or even an alternative diagnosis, or if the MRI is not consistent with the clinical diagnosis like we saw in our second case, in which there was a lower limb weakness, but apart from ring enhancing lesion, there was really nothing significant on the imaging. And then we go on to the last case, which is case 4, which is of a 13-year-old girl who presents to us with fever, headache and vomiting for 2 months, left focal motor with bilateral tonic-clonic seizure for 1 month, which was a single episode, and sequential vision loss right followed by the left over the past 1 week. She was conscious, but meningeal signs were present, and there was bilateral disc edema. The CSF pressure was, however, normal in this patient. Cells were 150 per cubic centimeter, and the neutrophils were 70%, protein of 52 mg%, and a sugar of 55 mg%. The CSF was done outside, so we don't really have the corresponding blood sugar in this patient. And this was a imaging which showed the leptomeningeal enhancement. In the flare, there were some hyperintensities in Jejira and sulci, and also periventricular. There were no microbleeds. And here is the last question for you. So what is the diagnosis? Do you think it's... Okay, so do you think it's chronic meningitis? Do you think it's vasculitis? Do you think it's demyelination? And do you think it's neoplastic meningitis? We go back there. Okay, so this is just for your, so most of the people think it's chronic meningitis. Okay, we'll get back to this. Don't look at those answers, they might be wrong. So we'll get back to our presentation, and we'll get all the answers here on the third heading, which is how to follow up patients. Because most of the lessons are learned during follow-up. And then we have a recapitulation of the first patient who, after 2 months of intensive phase, was not responding. And I asked whether you will start a second line treatment in this patient. Will you do a whole body PET? Will you do repeat CSF samples because she's not responding and it could be malignancy? Or will we give a prolonged course of steroids? What we actually did in this patient is that we indeed did a whole body PET, but it was not fruitful, it was normal. Then we gave an extended course of steroids for another 4 weeks. Fever and constipation symptoms resolved after tapering steroids. And after this, the symptoms recurred when we were off steroids and the symptoms were back. Then we repeated CSF twice over a gap of 4 weeks, and it was a similar picture even then. And then that was the time when we thought that it's high time that we switch on to continuation phase with recurrence of symptoms. Imaging remained the same. And then we started her on second line treatment. Now she's 2.5 years follow-up. We stopped antitubercular treatment second line after 2 years of ATT, and now she is clinically stable and back to work. So what were the lessons learned from this case? That the persistence of fever should prompt for close monitoring, but it may still be TBM. That there are some gray zones for the definition of multi-drug resistant tuberculosis in the situation of meningitis. The reason being that the isolation of AFB is difficult or sometimes rare. The history of prior incomplete treatment or contact may make the probability high, but it was not in this situation. And TBM is an easy inclusive diagnosis, but it is difficult to exclude. And from here, we can have a quick, recap of the studies or the evidence which has been collected so far on the anti-drug susceptibility pattern in the CSF fluid, especially in patients with TBM, because most of these have been extrapolated from patients who have pulmonary tuberculosis. But this was a review by Dr. R.K. Garg from Lucknow, published in 2013. A little bit of MDR, TBM and MDR TB regime has changed after that. But nevertheless, this is one of the most comprehensive reviews I came across, and it is worthwhile to see that most of these studies were a mix of HIV positive and negative patients. You can see that this study started with a very small number, and surprisingly, in most of these patients, the culture positivity rate was pretty high. Like in the Thwaites study, which I alluded to, which had 252 patients, and based on that, they had made that diagnostic index. All these patients were culture positive. We hardly get it in our scenario. Similarly, in another study in Vietnam, all the cultures were positive. And amongst them, the multi-drug resistant cases were a minuscule 10 to 11 cases. Here, the study from Argentina had all the culture positives, and they had a pretty high number of MDR tuberculosis. However, remember that in this particular study, all the patients were HIV positive, wherein in the Vietnam study, they were a mix of positive and negative patients. You would wonder that what is the situation in India? Do we have studies of TBM drug susceptibility from India? We have them, and there are a couple of them, the largest being the one with 2,325 patients in whom 256 were culture positive, but multi-drug resistant could be demonstrated in only 3 patients. This study was from NIMHANS. There was a study from MAMC of 100 pediatric patients in whom MDR was again detected in just 4. There was a subsequent study from NIMHANS with 366 patients in whom 9 were MDR. And I have included this study because it has a huge number. This was from Philadelphia, 1,896, which was a mix of HIV positive and negative patients. And we can see that they had no drug-resistant tuberculosis, tuberculous meningitis in their group. So, and then there is one study from a pediatric group in Lucknow, in KGMC, which looked again at the culture positivity in these patients. This particular study looks more realistic than I would say, or maybe this looks more realistic than the ones in which they were all culture positive. This was probably because they had taken only culture positive as the inclusion criteria, while if you look at this, which had a larger number of patients, this had a more realistic culture positivity. So we can see that a small proportion are multi-drug resistant, and we really don't have any criteria, and we are only lucky if we have a culture positivity, but till then we have to bank on other surrogate methods like we did in this patient. Now we go to the case 2 that I had asked you a question on, and just for a recapitulation, this was a 21-year-old male with typical history of fever, headache, and then right-sided weakness, and started on antitubercular treatment. Now this particular patient with lower limb weakness developed drug-induced liver injury, so we call it DILI, earlier it was called DIH. He was started on antitubercular treatment, which was modified because of DILI, and then after normalization of the LFT, he was restarted on the first line medications. Now he is 6 months into follow-up. He is clinically improved objectively, but has sensory symptoms still there on the right side. His repeat imaging was done, and it was the same. There was no interval change. So what lessons did we learn from this case? One is that arachnoiditis may be sometimes difficult to exclude on imaging, especially in acute situations. But clinical findings and interval changes as well as high proteins are fair indicators. And if you're finding things on examination, you should treat it like it could be possible arachnoiditis. You should go for serial examination in patients because myelitis may require a longer course of steroids. Paradoxical worsening and focal deficits may also be due to tuberculomas, and not only arachnoiditis. So that was, for people who marked tuberculomas as their answer, that might not be a completely wrong response because I had not shown your interval imaging. And patients of TBM with focal deficits have a worse prognosis. Now, we'll review a bit in context of this case about the complications of tuberculous meningitis. And this is one paper which has included patients from GV Pant, New Delhi, and Ibhas, New Delhi. This included 391 patients of TBM when followed them up for 1 year. The mortality was 16.3%, and 150 patients survived with one or more neurological disabilities, so they were still disabled. And the factors which were associated with a poor outcome were altered sensorium and focal deficits at the time of presentation, presence of seizures, having culture positivity, although made a difference in the neurological sequelae versus recovery. So there are two parameters which they measure. So they did not, the presence of seizures did not make a difference when the outcome was death versus recovery, but it was significant when the patient was left with good recovery versus sequelae. Okay, and this is another interesting case from which I learned that sometimes red flags need to be taken care of. So all myelitis with fever is not TBM, and this was a 50-year-old lady who was diabetic. She had 3 weeks history of fever with neck pain, vomiting, and 1 week history of great unsteadiness with diplopia. She had difficulty in moving the neck, so she could not move the neck at all. There was neck rigidity, and there was left sixth nerve palsy and left-sided ataxia and weakness. On the examination of the CSF, it was clear with 50 cells, proteins of 60, and sugar of 80 against a corresponding of 200. And this was her imaging. Now this is again not showing up very well, but I have a blown up imaging of this particular sequence of contrast enhanced, which shows that there is in the lower medulla an enhancing lesion which is almost forming a complete ring. And if you look a little carefully at this particular image, you would see that you can see this enhancement. This is the same image which I have projected on the subsequent slide. So the diagnosis made here, and they said that there's a bit of leptomeningeal enhancement, but probably because of this, the predominant symptoms could be very well explained. And based on the CSF and the clinical findings, we were happy. We gave her antitubercular treatment. She improved dramatically. We stopped AT after 1 year. And then she came back 2 years later with bilateral vision loss, which was acute onset, and fundus examination showed papillitis. And then on reevaluation, we did a CSF again, which shows 25 cells, all lymphocytes, protein of 80 mg%, sugar of 90 against a corresponding of 120. So here, this time sugar was not low, although protein was high. And the imaging showed that the cervical MRI lesion had kind of resolved and the brain was still normal. However, her serum and CSF NMO were positive. So from this lesson, it is important that you know that sometimes the red flags if you ignore the red flags and you go ahead with the treatment in the well-being of the patient, you still need to follow them up closely and look back at them so that you become wiser. So we come to the case 3, which was a 35-year-old man with fever, headache, vomiting of 2 months, and decreased vision and drowsiness for 2 days. And those were the possibilities which I had flagged. Could it be tuberculous meningitis? Could it be IIH? Could it be a dural AVF? Or could it be other chronic meningitis? So the problem here was that the cells were just 5. And all chronic meningitis are not TBM. And here drowsiness was a red flag for IIH. So the causes of fever with increased ICP is another favorite question which people ask the residents. So the causes are meningitis, multiple neurocysticercosis, or for that matter, any space-occupying lesions. Multiple tuberculomas could present that way. Acute demyelinating illnesses, like we had in the patient who had headache and vomiting with the sixth nerve palsy in the previous situation. Midline space-occupying lesions, metabolic abnormalities like hyperparathyroidism and thyrotoxicosis, and cerebral venous thrombosis and dural AVFs. So our patient, actually this patient which we're talking about, case 3, was being managed as IH from outside. The red flag was drowsiness. His CSF Indian came out to be positive. The cryptocol antigen was positive. This patient was HIV negative. Right now, he improved significantly after treatment and he's under a follow-up for the past 4 months with no recurrence of symptoms. So then we come to the last case, which was of a 13-year-old girl with fever, headache, vomiting again of 2 months duration with an episode of seizure and then vision loss with mild meningeal signs, disc edema, and the patient is still conscious. The options that were there were, could it be chronic meningitis, could it be vasculitis, demyelination, or neoplastic meningitis. Here in this patient, the cells were 150, the neutrophils were 70%, proteins of 52 milligram percent, and a sugar of 55 milligram percent. She had been started on antiplatelet treatment from outside. From this patient, which lessons did we learn? Of course, her diagnosis was not that. This patient was more positive. She improved dramatically with steroids and is a follow-up for the last 10 months on steroid-sparing agents and is doing well. So evolving spectrum of autoimmune diseases, which are known and maybe unknown biomarkers, can sometimes mimic chronic meningitis, can present with raised intracranial pressure with fever, and we should be ready to change our diagnosis, re-examine, re-diagnose these patients. So the causes of inflammatory non-infective meningitis are essentially neurosarcoidosis, acute demyelinating illnesses, especially in pediatric populations, neoplastic meningitis, Mollaret's meningitis, Behçet syndrome, VKH, non-steroidal anti-inflammatory drugs can sometimes mimic, antimicrobials like dimethoprim, sulfamethoxazole, amoxicillin, and isoniazid can present with inflammatory non-infective meningitis-like symptoms. There are some chemotherapeutic agents and monoclonal antibodies which can present with raised ICP and non-infective cause of meningitis like muromonab, azathioprine, IVIG, intrathecal methotrexate, intrathecal cytosine or rabinoside, vaccines, allopurinol. So there's a big list. Now, this particular patient's MRI report actually did mention whatever I had told earlier, but MRI cannot at all times differentiate between a chronic meningitis or a non-infective inflammatory meningeal enhancement, which can specifically happen in tuberculosis, in neurosarcoidosis. So here you can see that the possibilities written could be infective, could be also neuropsychosis. However, in this particular patient, it was MOG-related encephalitis. So they can present with a feature and mimic chronic meningitis. This would be my last slide, and the things that I would like to take as a take-home slide, as a take-home message is that you should approach a patient as is it meningitis rather than tuberculous meningitis. History will provide maximum clues, followed by examination, followed by investigations, and they should always be done in that order. The order is very important because if we jump to investigations, if we see the MRI first, if we examine the patient first and don't look at the history, we will probably meet a lot of challenges and mess up the case. So a close follow-up will help to confirm or change the diagnosis. And lastly, if a neurologist says that they haven't misdiagnosed a TBM as a non-TBM or vice versa, they just haven't seen enough. You know, if you go on seeing these patients, collecting the patients of chronic meningitis, you will see a plethora of symptoms, and you might see that somewhere, and most of the places you might be right, because tuberculous meningitis is the most common cause of chronic meningitis. However, if we keep following these cases closely, if we take a look at the red flags and follow them accordingly, then probably we'll be also diagnosing most of these cases correctly. Thank you. So I don't know if I'll be able to see the questions that you have posted. No, I can't see the questions that you have written in case. So it doesn't matter. Maybe once I'm in the ward, once you meet me, you can ask the questions. Thank you.